Myself, Dr. Mayank Nilay. I am Associate Professor at Postgraduate Institute of Child Health, Noida. I regularly manage kids with neuromuscular disorders, including spinal muscular atrophy. Spinal muscular atrophy is a genetic neuromuscular disorder, and mainly it affects the proximal muscles, leading to weakness of the muscles. There is degeneration of the anterior horn cells of the spinal cord, and gradually the disease progresses, leading to muscle weakness. There are various types of SMA: type 0, type 1, type 2, type 3 and type 4. Generally type 0, 1 and 2 are more severe, with early presentation and loss of mobility at an early age. Now, why it is important for the general masses to know about it? This is very important. Why? Because the carrier status of SMA is very high in India, and now we have any affordable treatment options, and if diagnosed early, treatment can be initiated. Now I will discuss about the early signs and symptoms of SMA. Suppose if you have a neonate or an infant who is having very floppiness in his muscles, who is not able to sit, or there is delay in the motor milestones, then you should suspect about spinal muscular atrophy. Generally, these children also have difficulty in feeding and respiratory issues. As I told before, the early diagnosis is important so that early treatment initiation can be done. Now, spinal muscular atrophy is a common situation in our country, but the main challenge which the patient families feel, and we as a doctors also agree, is the delay in diagnosis. There are studies from India which have shown that the carrier rate of SMA is 1 in 38. So, the number is very high, and it is an autosomal recessive disorder. So, if two couples having carrier status for SMA, if they marry, there is a 25% chance of having a baby with SMA. So, the main problem in India is a lack of awareness even among the clinicians, and that needs to be worked upon. There are currently disease modifying treatment therapies which are available for spinal muscular atrophy in India and worldwide. One is the gene therapy, which is Zolgensma. It is a bit costly, but it is a one-time IV infusion. The other option is an antisense oligonucleotide therapy, which is nusinersen or Spinraza. It is given intrathecally. Then we have a very wonderful orally available drug called Risdiplam, which can be given like a syrup form, and the cost has also decreased for Risdiplam as more and more companies are manufacturing at affordable rates in India. Now, these therapies are very important. Why? Because they, of course, they are going to change the outlook of the patients and the prognosis. Early initiation of therapy has led to the achievement in the motor milestones for these kids, and they also achieve more muscle strength, and the respiratory and feeding complications also decrease. So, very important aspect is an early initiation of therapy, which I have been repeating again and again. Multidisciplinary treatment is the cornerstone for the management of kids with neuromuscular disorders like SMA. By multidisciplinary team approach, I mean adequate support not only by the pediatrician, neurologist or the clinical genetist, but the active role of a physiotherapist, a nutritional rehabilitation specialist, and other doctors like endocrinologist and cardiologist, because most of the times these kids, even gastroenterologist is very important, because some of these kids may require a gastrostomy tube placement for their feeding, and chest physiotherapy. Pulmonologist is also very important, because most of such kids who are on therapy or even who are not getting any therapy, they get recurrent pneumonia and all those things, for which a combined team approach is very essential for a better quality of life. And the main outcome of all these supportive therapy, and if the child is also getting a disease modifying therapy, is an improved quality of life for the child, and also decreasing the burden of morbidity for the family, as the recurrent pneumonia and all those things decrease, and also the child achieves milestones. And in some children who are not able to sit, they may gain a milestone, they may be able to gain that milestone, and they may start sitting. So early initiation of therapy will surely help such kids. There are certain myths related to SMA which we encounter regularly in our clinical practice. The first myth is that nothing can be done and no treatment exists. No. Nowadays, with the advent of so many disease modifying therapies, as I told you before, there are a lot of good treatment options which, if initiated early, will surely going to help the child and the family. The other myth which I have encountered is that sometimes the patient family may ask, sir, is it an infectious disorder? No, it is not infectious, and it is not contagious. This is a genetic disorder which happens only when both mother and father are carriers for the disorder. The other myth I've found in my patients is that all SMA are fatal. No, all SMA are not fatal. I told you before, there are type 3 and type 4 who have a milder presentation and late age of onset, and most of them may be ambulatory as well. So all SMA is not fatal. And improved awareness about this disorder and counseling of the families is surely going to help. As I told you before, the carrier rate is very high, so we advocate pre-conception or even a premarital genetic counseling for the family and carrier testing for all couples who are at risk of having SMA and who don't even have a family history. They should get the SMA carrier testing done because the carrier rate is very high in India. So when you are able to know whether you are carrier or not, then it will help you in taking informed reproductive decisions. You can go for a prenatal testing or a pre-implantation genetic testing to prevent the severity of this disorder, because prevention is cure still in most of the genetic disorders. The other thing is that even if two people are carrier and they want to continue with the pregnancy without prenatal testing, they can go for a newborn screening of the child, and the child can be offered a newborn screening test so that early diagnosis and early treatment initiation can be done. So at least we now know that the access to SMA treatment is still a challenge in India, because still many patients are undiagnosed. There is a lot of lack of awareness, and even if the child is getting diagnosed, they feel the difficulty of getting a genetic test done. In SMA, MLPA for SMA can be done to detect the homozygous deletion of the exon 7 and 8 in SMN1 gene, which is not readily available. The other challenge was the high cost of gene therapy. We all know it is very costly, and then even the antisense nucleotide therapy, that is nusiransen, that is also costly. But right now, with the production of risdiplam by some indigenous companies at very affordable rates, now the drug is readily available to many kids in India and is surely going to improve the quality of life. And I feel personally the future of SMA care is very bright in India. Thank you.